Well, good afternoon, everyone. Thank you all for joining us this afternoon for our virtual quarterly meeting of the Interagency Heroin and Opioid Coordinating Council. We last met on June 10th, which was our first meeting since the pandemic had started. And of course, it caused us to delay the meeting a little bit, the quarterly meeting a little bit. But I'm glad we're able to at least come back to some sense of normalcy with our usual schedule, if not that we have to do it virtually for the time being. I want to thank you for your continued commitment to working to address Maryland's heroin and opioid epidemic. And you may have seen the most recent report with regard to fatalities. That data, which was released earlier this week by the Opioid Operational Command Center. Let me just ask if you're not speaking, if you can just put your computer on mute, because I'm getting a little feedback there, and I don't think I'm echoing myself. But Director Hsu is going to speak in greater detail about the report from the Opioid Operational Command Center with regard to fatalities, as well as the state response. But I did want to mention that the increase that we've seen, or mention that there has been an increase we've seen with regard to substance use disorder and overdoses that since the beginning of this pandemic. And it highlights what we've been saying, that just because the pandemic has taken hold to everyone's attention this year, it does not mean that the challenge of substance use disorder and addiction is any less serious, and that we can afford to turn our attention away from that very important issue. So in addition to hearing from Director Hsu, this meeting, we will also be hearing from our Secretary of the Maryland Department of Aging, Secretary Rona Kramer, who will give us a presentation on hospice care and the opioid crisis and implications in Maryland, or for Maryland, I should say. We will also hear from Dr. Aya Jones, Deputy Secretary for Behavioral Health for the Maryland Department of Health, a presentation on the state's opioid response and funding. And we will hear from Maryland's Department of Labor Assistant Secretary Jim Rybakowski, who will be discussing support for communities fostering opioid recovery through workforce development grant funding at the Department of Labor. With that, we will get started with today's agenda, and I'll turn things over to Director Hsu to discuss the 2020 second quarter fatality data. Mr. Director.
Thank you, Lieutenant Governor. Good afternoon, everyone. September marks a particularly appropriate time for this council to meet because this is Recovery Month. I want to thank Lieutenant Governor Rutherford for convening today's meeting and for his ongoing commitment to issues of addiction, opioids, and substance misuse, even in the context of these incredibly challenging times with the pandemic. I also want to thank Secretary Rona Kramer from the Maryland Department of Aging and Assistant Secretary Jim Rybakowski from the Maryland Department of Labor for being here today to provide our audience with more insight on how the state is dealing with the opioid crisis in innovative ways outside the purview of traditional health agencies. Finally, I would like to provide a special thank you to Maryland's Deputy Secretary of Behavioral Health, Dr. Aya Jones, for her leadership and tireless work on opioid and other substance use issues. The Behavioral Health Administration, BHA, is one of the Opioid Operational Command Center's most valued partners. We work with them on a nearly daily basis, and we appreciate their team support. As I think everyone's aware, the Opioid Operational Command Center and the Maryland Department of Health released our 2020 second quarter report earlier this week. The report outlines continued increases in opioid and other substance use related fatalities in Maryland. It's now clear to all observers that the coronavirus pandemic has created conditions that are driving increased substance misuse across the state and elsewhere. Next slide, please. Is everyone able to see the slides? Okay, well, let's pause for a moment. I think Brandy or Michael is in control of the slides. Let's see, could whoever is controlling the microphones, could you unmute Michael Corey and Brandy Kahn?
Sorry, just 1 second. Michael was having some issues, so I'm pulling it up now.
Okay, great. Technology, always challenging.
So it's saying that the host disabled any screen sharing.
Okay.
Hannah, are you?
Hannah, are you the host? Hannah Marr? Hannah, if you're speaking, we can't hear you. You're on mute.
Hi, Director. I just allowed them to have screen sharing access.
Great, thank you.
Sorry about that.
No problem. Next slide. Okay, if you look at the far right-hand side of this bar chart, you'll see that there were 1,326 unintentional intoxication deaths from all types of drugs and alcohol in Maryland during the first 2 quarters of 2020. This figure is a 9.1% increase from the 1,215 fatalities reported during the first half of 2019. Next slide, please. Opioids were involved in 1,187 of those intoxication deaths, representing about 90% of all such fatalities, and an increase of 9.4% when compared to the same period last year. We are especially concerned with the acceleration in fatalities as the year progressed. First quarter fatalities, which increased from 547 to 561, as you can see in the lower right-hand corner of the chart, were up only about 1%. But the second quarter, taken alone, was up about 18% from 1,085 to 1,187. Very concerning. Next slide. The synthetic opioid fentanyl on the left side of the screen continues to present serious challenges as it plays an increasing role in the majority of not only opioid-related deaths, but also all intoxication-related deaths in the state. There were 1,100 deaths involving fentanyl through the second quarter of 2020, accounting for 93% of all opioid-related deaths and 83% of all intoxication-related deaths overall. Fentanyl-related deaths increased by 11.9% compared to the same period last year. Prescription opioids, shown on the right of the chart, totaled 214 fatalities in the first half of 2020, an increase of 8.1%. This increase is concerning because prescription opioid deaths decreased by 3.4% annually last year. So that is a significant reversal. The only good news that I have to report at this point with these statistics is that there were 288 heroin-related deaths in the first half of 2020, a decline of more than 30% when compared to the first half of 2019. Fentanyl is basically elbowing heroin right out of the market, and there's every hope that heroin will disappear entirely from the market in the foreseeable future. Good riddance. Next slide, please. The state is also tracking recent spikes in fatalities involving non-opioid substances, including cocaine and alcohol. There were 486 cocaine-related intoxication deaths in the first half of 2020. That's a 13% increase from the same period last year. Furthermore, alcohol was involved in 287 deaths in the first half of 2020, almost 35% more deaths than in the first half of 2019. Shown in the middle of the chart, benzodiazepines, there were 62 fatalities during the first 2 quarters of 2020, representing a 24% increase compared to 2019. Methamphetamine up from 18 to 40, an increase of 122% off of a small base, but an alarming increase. And lastly, there were 32 PCP related fatalities during the first half of 2020, a decline of about 8.5%. It's good news. Next slide. It's worth noting that the vast majority of fatalities involving non-opioid substances also involved opioids. If you look on the far left side of the chart, you'll see, again, 486 cocaine-related fatalities, 92% of which, or 448, as shown in blue, also involved opioids. So it comes right back to opioids, and it usually is fentanyl. The figures were 80% for alcohol, 92% for benzodiazepines, 83% for methamphetamine, and 75% for PCP. So opioids were a factor in 75 to 90% of all fatalities involving non-opioid drugs and alcohol. Next slide, please. Increases in deaths related to non-opioid substances, even when considering that such substances are often mixed with opioids, are indicative of increases in substance misuse generally, and its exacerbation by the despair resulting from the coronavirus pandemic. Access to life-saving emergency services, substance use treatment, and recovery support has been disrupted by the pandemic. When you add the despair caused by economic uncertainty and unemployment, you have a very difficult set of circumstances for Marylanders suffering from substance use disorder, a perfect storm of substance use, overdose, and sadly, death. Next slide. Despite the complications presented by the pandemic, in fact, because of these complications, the state remains steadfast in its focus on this issue. We are truly fortunate to have the full support and commitment of Governor Hogan and Lieutenant Governor Rutherford in this effort. In June of this year, the state developed the COVID-19 Interagency Overdose Action Plan to provide a framework for continuing to battle the substance use disorder problems of our state, even in the context of COVID. From the beginning of their administration, Governor Hogan and Lieutenant Governor Rutherford have supported an all-hands-on-deck approach to solving this problem. So the OOCC is working with over a dozen partners, such as MDH's Behavioral Health Administration, to ensure that mortality reduction, treatment, and recovery support systems are in place for individuals in need. The action plan outlines several strategies that we as a state can use to fight the complications that the pandemic has created in the substance use crisis. The plan acknowledges that we cannot turn our attention away from the overdose crisis and that we must continue to advocate for programming that addresses the social determinants of health. You'll see each of the plan's goals listed on the screen. Within each of these goals, we've outlined specific strategies that will help us meet that goal. So just to give you one example, the first one, problematic substance use. Our strategies include to mobilize state partners to address adverse childhood experiences, or ACEs, because children are likely to experience a great amount of trauma as a result of the pandemic, from the disruption of school routine to those who are growing up in houses with food insecurity, abuse and neglect, and substance misuse. There will be increases in trauma. To use public awareness campaigns to disseminate information regarding substance use disorder during the COVID-19 crisis so that Marylanders know how to access the resources that they need. and to support vocational skills programs to support employment for individuals who've been displaced from their jobs during the pandemic. As Assistant Secretary Repkowski will attest, job skills and employment are incredibly powerful tools and a key to good health. We've also created an arrangement through the action plan wherein MDH and the OOCC are using new data sources to increase monitoring of overdose-related events so that resources can be directed to those areas of the state with the most need. The plan also acknowledges that COVID-19 mortality rates are highest among Maryland's minority communities, a condition that we are studying with our colleagues at the Maryland Department of Health. A copy of the plan is available for anyone interested and can be downloaded from our website, which is beforeitstoolate.maryland.gov. Again, beforeitstoolate.maryland.gov. Next slide. Of course, the state remains involved actively in distributing grant awards targeted at opioid and substance use. At the end of August, the OOCC awarded $9.6 million in state general fund grants to support community-specific programs aimed at stopping substance misuse where it begins. These fiscal year 2021 awards include $5.6 million in competitive grants and $4 million in block grants. The competitive grants will be used to address the needs of individual organizations around the state, while the block grants will be distributed among the opioid intervention teams that operate in each of Maryland's 24 local jurisdictions to fight the crisis in whatever ways they feel meets their local needs. The OCC's grant programs support Governor Hogan's policy priorities of prevention and education, enforcement and public safety, and treatment and recovery. And on the screen, you can see how last year's grant allocations aligned with these goals. The fiscal 21 grants will show a similar distribution. Next slide. Numerous other state agencies, we lost a slide, but I'll tell you what it says. There are numerous other state agencies involved in the crisis response who are managing large and very important federal grants, including two that you'll be hearing more about today. The Behavioral Health Administration's $50 million State Opioid Response 2 grant will begin distributing grants in October. The SOAR 2 grant will not only address opioid use disorder, but will also address stimulant, cocaine, and methamphetamine misuse and disorders. Additionally, the Department of Labor is directing $4.6 million in federal funding to 7 diverse local workforce areas comprising 14 jurisdictions across the state that have experienced negative social and economic impacts as a result of the crisis. And there are more than a dozen other state agencies involved in managing these grants. So to conclude, I'd like to thank everyone in attendance today for being part of the solution. It will take all of us to conquer this problem, but together we will succeed. Thank you, Lieutenant Governor.
Thank you, Director Hsu. I was told that some people are having a difficult time hearing, so I will try to speak up. There's not a master control in terms of volume, so I'll just ask that, if you are having a difficult time, that you possibly turn up your volume. I could hear you quite well, Director Hsu, from my tablet. Next, we're going to turn to Secretary Rona Kramer, our Secretary of the Maryland Department of Aging, to give a presentation on hospice care and the opioid crisis and implications for Maryland. Thank you.
Thank you, Lieutenant Governor and members of this council. We have discovered that there are unintended consequences of controlling the opioid crisis. And this consequence is that we have found that we are now having people who are dying in pain without having appropriate control over or pain management. This is also could come under the heading of no good deed goes unpunished. So here are our concerns. The slide one. Thank you. I'm not controlling the slide, so bear with me. There are impacts on end of life care. As we know, opioids, medications are extremely necessary to prevent suffering at end of life, and interrupting the availability of obtaining those drugs and medications has disrupted our pain management. This was brought to my attention by Dr. John Cagle from the University of Maryland, Baltimore, who has had an entire career in hospice and end of life care. And so he did a study, which he began in 2017, concluded the research in 2018, of 371 hospices. And 4 of those were in Maryland. So this was a nationwide study. And note that when we talk about hospice, I refer to both in facility as well as home care hospice. 36% of those hospices that responded, that participated, said that diversion efforts had created obstacles to them for pain management. And nearly half of them experienced drug shortages. Those numbers were higher for the facilities, the 4 Maryland facilities that participated in this study. And maybe meaning that we're doing a better job in Maryland of controlling opioids. So we now have inaccessibility, slide 2, to the drugs. Those are being caused, number one, by pharmacies that don't want the liability of carrying or dispensing large doses of opiates. They're not stocking it. Pharmacies are now questioning doctors more frequently about prescriptions that are written. And every time you have questioning going on between the pharmacy and the doctor, you're slowing the availability of the prescription being filled to the recipient. So there are delays then, and here, as well as later, you'll see delays with doctors. When those delays occur, patients are waiting sometimes days without their pain medication. These are end of life patients who are in extreme pain, and they're waiting. And once the pain level increases, it takes more medication and more time to bring them back to tolerable levels of pain. The drugs that are the most inaccessible are the morphines, fentanyl, and lorazepam. Community physicians are also fearful of writing large prescriptions, large doses. And they are also not writing them with refills. Those prescriptions, once you don't write with automatic refills, again, we have the same delays of the care recipient, the patient, having to interact with their doctor, and there are delays in doing that each time they have to refill the prescription. And the prescriptions now are being written for shorter periods of time so that the caregiver or the patient are going back and forth to their doctors and their pharmacies, sometimes weekly. And it's it creates a hardship on the family and of course, the patient. And why are the doctors doing this? They're all afraid of getting their hands slapped by their licensure board for writing these prescriptions. So they're very wary of them. A response to this from many of the hospice programs is that the hospice medical directors are actually stepping in, they're intervening, and they're writing the prescriptions. And they're more accustomed to writing prescriptions for large doses and for longer periods of time. And so that has been one response. Another concern that has been expressed, and this is by the patients, is that there is fear by the patients and their caregivers about using opioids now. So that there's a reluctance for end-of-life patients and also their caregivers to be giving those to them. So it's going to take more education by their doctors to explain that, yes, though opioids you are hearing are very dangerous, in this instance, they are serving a very valid purpose. And we're lacking in that education right now. There is definitely, slide 3, there are definitely issues with diversion of these opioids from hospice and from end-of-life patients. The majority of the problems are in people's homes and in small hospice facilities. The larger ones have improved their processes and they've got plans in place that reduce that diversion. But we have many, many people who are using either small hospice or no hospice at all. The most frequent offenders of diversion, people who are taking opioids from the patients inappropriately, are family caregivers, another relative, other patients in hospice facilities, and as well as privately hired caregivers. So and if we're seeing this in hospice, we have to assume that individuals at end of life who are at home just with caregivers and no hospice support, the problems have got to be even higher. So currently, as slide 4 in hospice, I had mentioned that some of the larger hospices are more effective, but many of them are doing what you see on your screen. They're doing pill counts, they're doing drug monitoring programs, staff testing, and staff training. But as you can see, there is still a lot of work that could be done to improve what is currently being done, because the better job we do of preventing this diversion, the better we will be at allowing our hospice patients to have the medications that they need. So we have our, the question is, what can we do about it? We can do a better job of disposal of unused opioids in home. Right now, the numbers that we believe are of opioids being left in the home are tremendous. We think that between 30 and 50% of the time after a patient has died, the opioids, the drugs are remaining in their home. And now the law has recently changed. The federal law, believe it or not, used to prevent anyone from coming and taking the opioids or the drugs from the home because they were considered part of the estate of the deceased. So that has changed. Maryland's laws were much better than the federal law, and but we still don't require in all instances that even hospice is allowed to take the medication and dispose of it properly. There is a very, you all know, I'm sure, that disposal is very simple, that we have the pouches that allow us to dispose and neutralize drugs very conveniently. I think we're not using them to the extent that we could. The Department of Aging had a grant awarded by the Maryland Opioid Operational Command Center, where we dispersed those disposal bags throughout the older adult community, and were very successful. We got excellent feedback about the use of them. So we know that there are methods. I believe if we do more education in hospice and with family members of end-of-life patients, we could do a much better job of preventing diversion. The Dr. Cagle convened a large group of experts on end-of-life care and pain management, and they came up with 15 recommendations for preventing medication diversion and misuse in hospice care. I believe, do we have a slide on that, Angie? There you go. So here are some of the recommendations. I won't go into a lot of detail about those, but there are a number of them, just briefly, that I think would be very easy to do and that we certainly should start considering. One is screening family members when when hospice goes into a home. Family members should be screened. We could have a family member sign a document that says they are taking responsibility for the opioids. We should have a witness to disposal of the drugs after the end of life of the family members, so that there is evidence, and even documented would be an excellent idea. And we could do a better job of letting family members know what is expected of them at end of life, and that these medications, it is expected that they will dispose of them and do so properly. So I would be happy to make the very long document of recommendations available to anyone who's interested. But I believe that we do have more work to do, both to prevent the problem that has caused the unintended consequence of leaving people dying in pain, as well as improving the patient's ability to receive the very important drugs that they need so that they are not going to die in pain. Thank you.
Thank you, Madam Secretary. Very good point. Early on and periodically, we do get responses, particularly on social media, with regard to the opioid, epidemic, that there are individuals who are either in pain management or folks that are, have family members in hospice care, that they are very concerned that they can't get access to these opioids. So that is a concern that has been out there. In terms of disposal, I've participated for a number of years in Howard County on their drug take back day. They usually have it 2 days a year. And the majority of the people that are coming through with large amounts of drugs of all sorts are family members where a family member had passed. And in some cases, they're saying that it took them a long time to even take those drugs back. So they sat in their homes or sat in another family member's homes for a long time because the surviving family member in their grieving process wasn't ready to really, lack of a better term, purge some things, and it included their medications. They weren't ready to dispose of the medications because when they saw them, they, felt that that meant the person was there. And so it's a challenge that we have to deal with. And maybe those end-of-life counselors can have those kinds of conversations with the families to say that at least, let's properly dispose of any medications that you have at the house. Okay. Well, thank you. I think we turn now to Dr. Jones, Dr. Leah Jones from Department of Health, the Deputy Secretary for Behavioral Health.
Good morning, and thank you for this opportunity to share the work, important and good work done through the State Opioid Response Grant and the team that does that hard work on a daily basis. So thank you, Lieutenant Governor. Let's see. Okay. All right. So the Maryland Department of Health has been awarded, as Steve mentioned, $50.7 million from the United States Department of Health and Human Services, SAMHSA. And this grant, SOAR 2, is going to be used to enhance treatment, prevention, and recovery support for opioid and, fortunately, stimulant use disorders as well for the first time, increasing that those access to those services. The grant funds in general are going to be used to increase access to evidence-based treatment using medications, to decrease opioid overdose-related deaths through these treatment medications, and also treatment programs of various forms. And then, as mentioned, also to address the stimulant use disorder challenges that we have as well. Though they have a smaller overdose rate than the opioids, they still present significant morbidity and mortality to Marylanders. So we're happy that we're finally getting more funds and understanding that we have more than an opioid problem in the United States of America. Our SOAR 2 application development involved multiple stakeholders, including reaching out to our local behavioral health authorities, our state agencies through the OOCC, and our numerous community partners. And so you'll see that many of the programs that we are intending to fund are various in nature, hitting lots of different points of service need throughout the system of care. So before we talk a little bit about what it was that we are going to be doing for the SOAR 2 funds, I wanted to mention some of the things that we're proud of regarding the first set of funding, the SOAR 1 funding, which covered periods of September 30th, 2018 to September 29th of 2020. With regards to efforts at prevention, we are very proud of the number of naloxone dosages that were distributed, 86,766 doses that were distributed, and 43,288 individuals trained in how to administer naloxone or how to save a life. So very proud about that. Our public awareness efforts continue to be very effective, and we continue to get a very large number of impressions for that work. I'd also like to highlight the number of harm reduction interventions we've made over this period of time. So 47,902 different individuals went through our harm reduction outreach programs or service through these efforts. So that's wonderful because though these persons may not have been interested in treatment at that time, that's 47,000 more people who know about how to access the treatment system, which has been arguably difficult to navigate historically. So we're looking to change that, and having people go through those programs, it really does help with that. With regards to treatment and all of the work that's been done in that space, I'm happy to report about the medication assisted treatment reentry support that we were able to provide in support of HB House Bill 116 that requires that all FDA approved medications be provided in local detention centers at screening and reentry. So we had 505 unique individuals who received training there. We're currently providing funds in four jurisdictions in Howard County, Montgomery County, and Prince George's and St. Mary's counties that support this legislative mandate. These jurisdictions were identified as part of the phase one implementation. And as you all well know, when someone is incarcerated, one of their greatest opportunities for relapse and for death is upon release from their incarceration. So this helps to prevent people from overdosing when they get out of an incarcerated situation. Very excited about our expert expansion, and so that we have a comprehensive approach to managing patients in the emergency department who have opioid use disorders. We have 3 interventions that work through our EDs across the state: our screening, brief introduction, and referral to treatment services, our opioid survivors outreach program, which reaches people who come into the emergency department after or during an opioid overdose and follows them once they leave the hospital. And then also our hospital-based buprenorphine induction, which connects people to or starts people on buprenorphine when they're in the ED and connects them to programs before they even leave the ED, so that they can get connected to services immediately. You're much more likely to get that person to stay engaged in care if you take that approach. So very happy about that work. We've also, so we've been able to expand these services to an additional 8 hospitals over the past 2 years. And we also expanded the expert services into 8 hospital mother-baby units and to their feeder OB/GYN practices and 4 college health centers at the University of Maryland College Park, Morgan State University, University of Maryland Eastern Shore, and Johns Hopkins University. So again, just efforts at making sure people know how to, that the disorders are being recognized and that people are getting, their hands are being held as they get connected to resources and support. And I'd also like to highlight our crisis services, our crisis beds, the number of people who were able to access them, our numbers of crisis centers, and our safe stations utilization, as noted on this chart. So lots of great work happening here. And then as it pertains to recovery, I'd like to note the Healthy Beginnings program, which is a very small program for pregnant women in Calvert County to prevent neonatal abstinence, or at least to prevent the numbers of babies exposed to opioids and to try to decrease the incidence of neonatal abstinence or severity of neonatal abstinence after these babies are born. You are going to hear about the partnership with the Department of Labor and Licensing, the workforce development programs. We provide an opioid workforce innovation fund through SOAR funding, which is awarded to organizations with the goal of developing training programs that credential individuals who have been impacted by the opioid crisis in industry-specific and in-demand areas. So as Steve mentioned, having jobs is critical to helping people to desire recovery and to stay in the recovery process. So we're very happy to be supporting that work. And we are also happy to announce that we'll be increasing our funding of this initiative through SOAR 2 funding. So with regards to the SOAR 2 programs, there are 3 components. From an administrative perspective, there's the data management parts, performance evaluation, and then the management of the actual grants themselves. We have lots of prevention programs that we are going to be supporting, and I'll highlight the new ones, which include our expansion of our HBCU Behavioral Health Student Expansion Program, our Native American and Tribes Evidence-Based Initiatives, and our Substance Use Disorder Workforce Expansion Fellowship. And with regards to programs for treatment, the newer programs are a medication adherence technology, which using some innovative ways of helping to ensure that people are compliant with these control medications in their home settings, and our residential substance use disorder treatment for women and children. So excited about that. And to note that we have peer recovery specialists embedded in our crisis services and our medication assisted treatment programs within the detention centers. Regarding our programs that support recovery, we are expanding our service for recovery housing for adults and young adults. Our Healthy Beginnings program, which is for pregnant women who have children and women who are in the postpartum stage. Our intensive care coordination, which provides care management and recovery support services to those who are at high risk of overdose upon release from detention centers, and again, our workforce development programs. Some of the new initiatives that we'll be embarking upon are listed here, and I will just mention, I mentioned the electronic pill dispenser previously. We're looking to do a lot to improve workforce development through our partnerships at HBCUs, and also the School of Social Work partnership that we have with the University of Maryland, looking to help improve the capacity and quality of our peers through funding peers to get certified, providing more training for expert, and providing more resources for expert in primary care settings, as we know that most people who have substance use and all behavioral health conditions are seen much more so by their primary care providers than by any specialty behavioral health provider. Providing additional support for stabilization centers and crisis beds, looking to bring online some young adult recovery housing, which we know is very much needed, and then also funding for our local crisis hotlines and improvements there to increase access to care. Most of the programs that we were funding under SOAR 2 will continue to be funded, and what you see before you are a list of the programs that we'll be continuing to fund through SOAR 2 funding. And so in summary, the SOAR 2 funding is going to go from September 30th, so that's next week, to this year to September 29th of 2021. Oh, pardon me. So that was SOAR Year 1 funding. SOAR Year 1 funding. No, I'm sorry. SOAR 2 Year 1 funding. So it's one year consecutive after another. So they start September 30th of each year and they end September 29th of the following year. And we have 32 initiatives across 24 jurisdictions in the state of Maryland that are going to be funded with these resources. Of note, we've also applied for a no-cost extension to continue our activities through SOAR 1 funding. We have about $33 million that has been allocated. And this is going to support adolescent clubhouses, recovery housing for young adults, the hub and spoke model, to increase access and to care for people for opioid use disorders, making sure that if you have a greater severity need, you're getting treatment where you need to get treatment, but then as your needs decrease and you can be managed more by a community provider, people will be able to have that access to the hub and spoke model. And then also funding for our minority outreach and technical assistance grants, and then for our grants management systems. And so to end, I'd just like to express appreciation to the members of my team who live, eat, breathe, and sleep this stuff. Marion Bland, who is our Director of Clinical Services for Adults and Older Adults, Ms. Shantae Hunt, who's our SOAR Program Director, who's on the call today, and Kimberly Qualls, who is our Director of Office of Treatment Services, who do a phenomenal job every day managing this phenomenal resource for the state of Maryland. And if you have any questions, if we get to that point, they're likely going to be the ones who are going to have the best answers to your questions, and I'll do the best that I can. And so I'll turn it over from there.
Thank you, Dr. Jones. You mentioned recovery housing is something that's going to be continued to be supported. I know from a lot of the work that we've done over the last several years, recovery housing has been an issue, both in terms of getting people into those type of facilities, but also even on a local level where the local zoning and the population is not, population meaning the citizens that are around don't really understand what it is. They think it's either a treatment facility or they think it's a halfway house or something that they don't want in their neighborhood, the NIMBY approach. And so it can sometimes be very challenging where it's really, I was going to say it's a safe place for people who are in recovery, that they can go to work, they can come home, they can have some counseling that comes in, kind of almost like the Alcoholics Anonymous, the support structure, versus them returning back to wherever they were before that has the stimuli that may make them, fall off their recovery track. So how has that gone, and are the communities getting a little better in understanding this?
Unfortunately not. Stigma is still a very real issue and a problem that we continue to face when it comes to substance use disorders. Everybody recognizes that people should get help. They just don't want them to get help around them. So that's a real issue and a real problem. We continue to use our funding to provide educational announcements and just trying to help educate and inform the communities about the importance of recovery. And then it becomes incumbent upon individual providers and organizations to work those communities and to try to get better partnerships, and then also to be good neighbors to those communities, which makes it easier for other providers to set up shop versus providers that are not as responsible, and then that just makes it harder for everybody else who wants to make sure that we're providing these vital resources for people who are in the recovery process. But it's a battle that continues to be fought, and I'm sure that we will continue to support fighting that battle as long as there continues to be a need.
Okay, that reminds me to follow up on something we were trying to do in Baltimore City, or a facility that is state-owned, that the department that was custodian no longer needed it, and we had talked about utilizing as recovery housing in the city, which is something that's particularly needed there. And the local council person and the delegate and the senator all wanted it to be something very different. And so I have to find out whatever happened there and see what's going on. Okay, well, thank you very much, Dr. Jones. I'm going to turn now to Assistant Secretary Rybakowski from Maryland's Department of Labor. Jim, good to see you.
Good afternoon. Certainly. Good afternoon, Lieutenant Governor, members of the Coordinating Council. I'm Jim Rybakowski, Assistant Secretary of Labor, on behalf of Maryland's Labor Secretary, Tiffany Robinson. I'm pleased to provide an update on recently announced grant funding, as well as other workforce efforts in this space. On the call, I am joined by Mary Keller, who is our Special Grants Administrator at the Maryland Department of Labor and oversees our opioid grant programs. During the call today, we've talked about loss and pain, but we've also talked about recovery, and I want to continue that shift in focus to recovery and how a job, moreover a career, is critical to recovery and an individual's self-worth. This month, the Maryland Department of Labor was awarded $4,589,000 from the United States Department of Labor as part of their Supporting Communities Fostering Opioid Recovery through Workforce Development Grant Program. Only 3 other states were awarded this funding: Ohio, Wisconsin, and Florida. So we are pleased to be able to bring home funding for Maryland. As Director Shu mentioned, Labor will disperse this funding to 7 local workforce areas representing 14 jurisdictions across the state. The Western Maryland Consortium, which consists of Garrett, Allegheny, and Washington County, 4 freestanding counties of Frederick, Anne Arundel, Baltimore County, and Baltimore City, the Susquehanna region consisting of Cecil and Hartford, and the Upper Shore, which is Caroline, Dorchester, Kent, Talbot, and Queen Anne's. More than 700 Marylanders are expected to participate, including those that have been directly impacted by opioid substance abuse disorders, or those that seek to transition to professions that support individuals with substance use disorders and need to upgrade their skills to better serve struggling or at-risk individuals. Participants will receive a wide variety of comprehensive services based on individual treatment plans, including occupational training, career and supportive services, and outpatient recovery care. Ultimately, participants will have the opportunity to obtain employment in in-demand sectors, including healthcare, information technology, transportation and logistics, construction, and manufacturing. Partnership is vital to success of this grant, and each local area is partnering with various stakeholders, including local health departments, recovery and wellness centers, occupational training providers, community colleges, and local government entities. Maryland Labor would like to thank the Opioid Operational Command Center and Maryland Department of Health for their unwavering partnership on Labor's efforts to secure this funding. The start date is October 1st, and we have a 48-month period of performance. I have some other grants I'd like to update you on as well. This new USDOL grant comes on the heels of Labor completing a National Health Emergency Grant totaling $1.9 million through the U.S. Department of Labor ending June 30th of 2020, in which more than 1,300 individuals impacted by the opioid crisis were served. Of that, $1.1 million was invested in our Opioid Workforce Innovation Fund, funding 16 different entities, mostly nonprofit organizations, and with $700,000 going to 8 local workforce development areas. As Dr. Jones stated, Labor also partnered with the Department of Health, which provided $200,000 to the Opioid Workforce Innovation Fund in 2019. There were 3 subgrants awarded. Civic Works, located in Baltimore City, they provided occupational training in the green space for individuals impacted by the opioid crisis. Dr. MJ LLC, located in Prince George's County, trained 50 certified peer recovery specialists. And the third grantee was Voices of Hope, located in Hartford County, training 25 individuals to become certified peer recovery specialists. Just recently, as was mentioned, we learned that Labor will receive a little over $1 million from the Department of Health to support our Workforce Innovation Opportunity Fund. It is anticipated that 14 organizations will receive funding, impacting at least 175 individuals that will be served. In 2019, Labor received funding from the Opioid Operational Command Center to pilot a career recovery specialist training at Maryland Correctional Institution for Women, MCIW. 23 women completed the classroom training, but were unable to begin earning their 500 work and volunteer hours required for the certification process due to restrictions of COVID-19 within the prisons. In August 2020, Labor received additional funding from OOCC to continue this work and support the women as they move towards certification. Those funds will be used for curriculum review, continuing education credits, and the cost of certifying the women who have participated in the program. Lastly, in 2018, Labor received $650,000 from the Women's Bureau of the U.S. Department of Labor. The funding is being used for a pre-apprenticeship hospitality pilot at Maryland Correctional Institution for Women and to fund 2 larger OWIF style projects. At the Maryland Correctional Institute for Women, the pre-apprenticeship hospitality pilot is in close partnership with the Department of Public Safety and Corrections and the American Hotel and Lodging Association. The first cohort launched with 12 women enrolled and was close to completion until COVID-19 shuttered movement of the inmates in the facility. Thanks to Labor's close partnership with Public Safety and Corrections, the instructor of that hospitality program is set to reconvene their classroom instruction, of course, adhering to all the safety protocols that are in place. 2 additional cohorts are planned for the hospitality program, and that grant ends in September of 2021. There were 2 competitive RFPs under the Women's Bureau grant. We had 2 subrecipients. One was Maryland New Directions, located in Baltimore City. They're set to train 50 women for careers in transportation logistics and hospitality. In addition to job training, case management, support services, and wellness services will also be provided to those participants. The other grantee was Pivot, a Baltimore City-based community reentry and workforce development program for women. They will engage 45 women, enrolling them in an 8-week program where they will be exposed to job readiness, group therapy, intensive case management. Following the 8-week program, the women will be placed into employment or referred as appropriate to occupational training opportunities. Both organizations are working through COVID-related challenges, but they are all expected to resume their programs and meet their deliverables for the program. And that Women's Bureau program ends on September 30th, 2021. So Lieutenant Governor and members of the council, I appreciate you allowing me the opportunity to share what we're doing at Maryland's Department of Labor as part of recovery. Thank you.
Thank you, Jim. Thank you very much. Are there any, questions of any of those who were presenting today? Does anyone have any questions for them, or just generally have anything to share?
Can I just ask, are we going to have access to the presentations or reports that were given today? It'd be great to have and refer to.
Yeah, we can send out the ones we have. I don't know, do we have Labor's? I don't remember. I didn't see.
I can send you the printed comments. It was not put into a PowerPoint.
Yeah.
Okay.
I can, Lieutenant Governor, I can operate 2 screens on my one monitor. If I had a third, it would have been pandemonium.
No, I think written comments are great. Thank you so much. The only other thing I did want to remark on was the statement about challenges with access or challenges with access to substance use treatment programs and services during the pandemic. And I just wanted to be clear that everyone understood that we didn't actually have, we just did a pulled from licensing activity of all of the behavioral health providers and programs in the state. And between May of 2020 and September 20, we've only lost 2 programs. So we have had some programs did have to make changes in the way that they were operating so that they could operate in a way that was safe. However, the overwhelming majority, 90+% of behavioral health programs continued to remain open during the pandemic. We did have our 12-step programs, most of which went offline and went into a virtual environment. However, we also provided guidance very early on in the pandemic that 12-step programs were not they were not banned from operating during the pandemic. The governor and lieutenant governor supported the continuation of 12-step programs. And what the Behavioral Health Administration did was provide guidance around how to do it safely, though we did encourage people not to do a lot of face-to-face during that time, particularly earlier in the pandemic. So there's a lot of that's being said that programs were closing. And I know that that was happening all over the country, but in the state of Maryland, we did not have a mass closure of behavioral health programs during the pandemic.
And if I might, Lieutenant Governor, I'll just clarify my comments. When I did reference that in my presentations, it was those programs that are located within the state's prison facilities where inmate movement was canceled because of fear of the spread. So when we can't move students because of the congregate environment, our programs outside of the fence similarly remained operational of course, exercising the appropriate protocols and leveraging technology where appropriate. Those comments were really targeted towards the ones behind the fence where we couldn't bring the students in.
And I honestly, I wasn't even talking about your comments, but
It gave me a chance to say something else. So I thank you, Dr. Jones.
we've heard that a lot, and that's
I
something
like to talk.
and so, as you can see, so do I. But the Behavioral Health Administration and maintaining access is something that was really, really critical to us, which is why we tried to provide as much guidance as we could to make sure people knew how to operate during this time to prevent lack of access for behavioral health programs and lack of entry for people who were new to the need for behavioral health services. So, so that's something that we've been following very closely. Now, things are changing now, to be quite frank, which isn't really pandemic related, but related to some other issues. But during the height of our curve, things were changing, but people could still access services.
Very good. Any other comments or questions from our group? Director Hsu, anything to add?
Not from my end, Lieutenant Governor. A lot of good discussion today.
Okay. Well, thank you all. Thank you very much for your continued commitment and involvement in this process. We still have challenges going forward, and I'd be remiss if I didn't say that we also, in addition to the challenges that pandemic has brought in terms of those who are in recovery, it also has had a negative impact on those who are suffering from mental illness. And as you know, many cases as co-occurring conditions or that they have in terms of substance use disorder, as well as a mental health issue as well. So thank you all for the participation, and keep up the good work. Take care.
Thank you, Governor.
This afternoon.